Welcome to Dermatology Morning Commute, the pathophysiology behind Prurigo Nodularis. Morning Commute is developed by Projects and Knowledge, powered by Kaplan, and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Sanofi and Regeneron Pharmaceuticals. What is the itch-scratch cycle? In our fourth podcast on Prurigo Nodularis, Dr. Sean Quatra and Dr. Serena Amaria look at the inflammatory and neuronal processes that lead to the development of a positive feedback loop that propagates itch without further stimulus. Information about the faculty and disclosures can be found at morningcommutepodcast.com/P-Nodularis4. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Quatra is an associate professor of dermatology at Johns Hopkins School of Medicine in Baltimore. Dr. Almaria is an assistant professor at Harvard Medical School and part of the faculty in the Department of Dermatology at Massachusetts General Hospital in Boston. I am your host, Candace Hoffman. Dr. Quatra will begin our discussion.
Serena, in our last podcast, we talked about systemic treatments for Prurigo Nodularis. Now let's turn to better understand the pathophysiology of PN. And previously, we'd known very, very, very little about it. And what we did know was sandwiched into our broader understanding of itch. Now we're learning a little bit more about what's unique about PN and in terms of this interplay between inflammatory and neuronal processes. So would you mind setting the stage for the pathophysiology of Prurigo Nodularis?
Sure. Thank you for this. I think the pathophysiology of Prurigo Nodularis is really fascinating. And really, I do want to emphasize that our understanding of the pathophysiology is evolving. So, from work that's been done over the last decade or so, we have known that there are both immune components as well as neural components. And traditionally for years, in part, I think because some of the research was done by immunologists, we kind of focused on the role of increases in eosinophils and eosinophil released factors, how those increases in eosinophils and the burden of eosinophils would lead to a more complex immune soup, if you will, which I know you're going to touch on later, but how that would then influence the development of a nodule. And this could be found at the base of nodules or within nodules, and sometimes even in like the tightly kind of surrounding skin. But there has been evidence for immune dysregulation for some time. I'd say a little bit more recently, but still, even in the last, several years old now, we have known that there is also a very heavy neural predominant impact as well. And so work many years ago by Sonia Stander and her group showed that PN within the PN lesion, that there can be decreased actually intraepidermal nerve fiber density that was thought to lead to a dysregulation in kind of just sensory processing, so that there would actually be more incoming itch and less, pain or other sensory phenomenon that could downregulate the itch sensing or gating. We have subsequently realized that there is actually an increase in dermal nerve fiber density as well. And so I think, again, along that theory, right, there may be of those cutaneous C fibers or unmyelinated kind of itch and pain sensing fibers, there is a dysregulation that leads to a fueling of a chronic itch sensation. But again, as we talked about in one of our earlier podcasts, a lot of these patients experience, burning or tingling, prickling. And so not simply itch, but it could be, this dysregulation of epidermal versus dermal nerve fiber density may influence those other symptoms. Now, how these two components of immune dysfunction and neural dysfunction lead to the characteristic nodule, as well as the fibrosis that you have actually mentioned is really, our understanding of this is still evolving. I don't know if you actually, maybe now's a great time for you to talk about some of your work and some of the findings that you've had.
Sure. So I think that's a great segue. So we'd known very little about PN in comparison to atopic dermatitis and psoriasis in terms of the immunological basis for it in both the skin and the blood. And so what our group did is we actually did skin biopsies from PN patients, both their nodules and the healthy appearing skin, normal appearing skin. And we did sequencing to see what was different about those nodules, like what were the different molecular mediators in those nodules. And also we looked at the blood to see what were the different parameters that were dysregulated. And actually we found some very interesting things. We found that there's different immune axes that are upregulated. So we confirmed that there is absolutely from both the skin and the blood novel immune dysregulation in Prurigo Nodularis. We looked specifically at a few different axes. The type 2 inflammation or IL-4, 13, 31 are all implicated, but also other axes, especially in the nodules. There's some Th17 and 22 activity, which are associated with skin thickening as well. And in the bloodstream, we also found, very interestingly, increased circulatory inflammatory cells. So one of them was called gamma delta T cells. So these are actually very interesting because they're important in other comorbidities, so like chronic kidney disease, other things like that. And those are increased in Prurigo Nodularis patients in their bloodstream. Also natural killer T cells, CD4 and CD8 T cells, which are a lot of these immune signaling cells that are involved in the pathogenesis of PN. So all of those mediators are involved. When we looked specifically at Prurigo Nodularis versus atopic dermatitis and psoriasis, what was so interesting is that we found very fibroproliferative genes. So many of the genes associated with thickening of nodules, also more neural dysregulation. So building on what you said, when we looked at all of these different neurally encoded genes that are involved in itch sensation and also neuron biology, we found that those were dysregulated more in PN than even atopic dermatitis and psoriasis, which really highlights that origin of what's going on. So those
Sean, can I actually ask you a quick question there? So does that include things like calcitonin gene-related peptide and substance P, which many people are familiar with, or many, dermatologists I know are familiar with the concept that these neuropeptides can be associated with itching disorders, but also with neurogenic inflammation. Are those also upregulated in Prurigo Nodularis?
Absolutely. So 100% that those are dysregulated in Prurigo Nodularis. And I think it's really interesting that there is this crosstalk that's going on. So as we know, these neuropeptides are released by sensory neurons, and they actually act directly on the immune cells. So calcitonin gene-related protein, substance P, VIP, all of those things act on immune cells. So released by those sensory nerve fibers and that itch sensation, the immune cells like the eosinophils, ILCs, mast cells, macrophages, T cells, dendritic cells. And then what we have is that exactly what you said, that cutaneous neurogenic inflammation that's mediated by these peptides and then stimulating also this immune system dysregulation. It's bidirectional also. So absolutely that's part of what's going on. And what's so fascinating is that it's not just those neurogenic inflammatory peptides, but also IL-31, IL-13, IL-4, all of those mediators hypersensitize neurons and then lead to neuronal sensitization. So actually we found all of those receptors on those nerve endings.
Yeah, I think that's a really important point, is to recognize, and really when we talk about the neuropeptides, it's just that is a hallmark of our kind of classic understanding, right? They can be released by the nerve terminals themselves, but really also other cell types, immune cells can release these, and they influence not only the neural activity, but they also influence the activity of other inflammatory cells, their recruitment, their production of cytokines. lesions. There's data in other inflammatory skin disease models like psoriasis and atopic dermatitis that show that they can fuel that as well. But they're also obviously talking to endothelial cells, and that can influence kind of the health of the tissue as well, right? Of the dermis and the fibroblasts. And so, people often have said about PN patients when we talk about this perception that it's just a picking disorder or that it's psychiatric, is that they're inducing these lesions. And certainly there is a kind of vicious cycle that fuels this, the development of the PN lesion. But obviously, and some of the work that you're doing shows that there are predispositions for there to be cytokine dysregulation, right? Not just that they're being released as they would be released by anybody who traumatizes their skin, but it's not like every time we get a cut, right, that we go on and develop PN, or that we have a bug bite that we develop PN. So clearly there is dysregulation of how nerves and the immune system react in the setting of this trauma that is unique to PN in particular.
Yeah. And, we actually have, building on what you're talking about in terms of that neuronal sensitization, the immune crosstalk, we know that there's also several of these mediators that are also correlated with itch intensity, like IL-31, IL-31 receptor. And also actually our group recently did a study that's published as a preprint online right now, undergoing review. And what we found is there's more IL-13 in Prurigo Nodularis patients. There's also in their blood, there's also more of what we call periostin, which is one of these proteins that are involved in extracellular matrix remodeling. There's thoughts that it's also involved in itch transmission. It's associated with type 2 inflammation as well. So that was another very interesting finding that we have about kind of the biology of PN and how we're truly appreciating a lot more. Another study I want to bring up to you guys is a study that we did about the blood signature of Prurigo Nodularis. And we looked at plasma biomarkers of Prurigo Nodularis. And I talked to you about several cytokines before, but one thing that we also found that's very interesting, I think, is that there are various intensities of the different cytokines that folks can have. So crossing across immune axes as well. But one thing that we found, and we actually validated that in a larger study, a larger panel of patients, was that actually Black patients with PN tend to have a much higher degree of systemic inflammation across a variety of cytokine markers, also C-reactive protein, greater blood eosinophils, erythrocyte sedimentation rate than Caucasian patients and other patients. And I think that highlights a lot of what we talked about with PN in terms of race. So Black patients have more fibrotic nodules, in my view, oftentimes thicker, much more dense nodules. And there may be a genetic predisposition to it in these patients, but what we're also highlighting is that there are very important components of social determinants of health in PN. We know that minorities in this country are more likely to have many of the comorbidities and greater severity that are associated with PN, chronic kidney disease, type 2 diabetes. These are epidemics in many of our urban minority skin of color patient populations. They have higher systemic inflammation. They have greater disease severity. So I think a lot of these things are tied together, bridging the molecular, the pathophysiology, also with kind of a broader context of disparities in Prurigo Nodularis and what we're experiencing. So that was something I also wanted to highlight, to bring on your radar, is that there are important societal factors that are also manifesting in how we see these patients and how they present.
Well, another, important point with that is, we have always looked at PN from the perspective of what diseases or comorbidities, right, do individuals have that led them to have PN? And we've already talked about the merits and the reasons, for that argument, but also against that argument, right? Like PN is a disease in and of itself, and does not necessarily need to arise in the setting, for example, of chronic kidney disease. But you mentioned a point, and I want you to expand on it, if you might, for a moment, the fact that in patients who already have PN, right? There are risk factors then that are increased for developing chronic kidney disease or other disorders. And so where do you think, I'm just curious, I'm kind of asking you to hypothesize kind of off the cuff here, where do you think in the landscape of PN that really starts to have an impact? And, just one question is also, do you, in your experience thus far and in your research, have you seen that the severity of PN actually makes a difference for those patients who are more likely to go on and have other systemic disorders?
Great question. I honestly believe that greater disease control of PN will lead to less comorbidity development. And I think that that's where it's going, because a lot of these circulating blood inflammatory mediators that I mentioned are associated with these other conditions, chronic kidney disease, type 2 diabetes, all of those things. And many of the patients that have uncontrolled type 2 diabetes tend to have the most severe prurigo nodularis. So I honestly believe that this inflammation and stopping it is better for a variety of different disease comorbidities. And I think we'll end up seeing this through longitudinal data now that some agents are closer to the finish line. But I truly believe early treatment will allow for a lot of these other conditions and their management and how they evolve to not even appear, and for folks to have better quality lives. Because think about it this way, right? You're itching all day. You're not sleeping. Just not sleeping is known by itself to elevate blood glucose. It's known by itself to make you more likely to get all these diseases, like that alone. And then if you think about, it's actually decreasing specific elements of inflammation that we know are associated with these things. So I think that's really the frontier, is explaining that element to patients. Whenever I do, and I talk in that depth, they're like, oh man, we shouldn't have waited so long to treat this and get on top of it.
So I love that you highlighted that. And that's actually what I was hoping you would do, because I've had, again, this is a little bit more anecdotal, and also just intuitively, right? I mean, it does make sense that if you have uncontrolled inflammation in your body, you are going to be at higher risk of other long-term comorbidities. And we've seen that with cardiovascular disease. We've seen that with diabetes, as you've said, other metabolic disorders, and they really go hand in hand. And so I think that is a very important point. At some point, our goal, right, when we even think about what is the treatment for PN, it obviously, right, is to break the itch scratch cycle. It's to reduce the burden of disease, and it's also to either highlight potential predisposing conditions, but also really now, I think, with this evolving insight from your work and others, that these patients are at higher risk for other disorders, even beyond just depression, anxiety, and quality of life issues. So, when we're thinking about how to intervene, right? How do we break that cycle? We have to start really honing in then on the pathophysiology. And this is where, in the past, we may have relied on broad acting immunosuppressive or broadly acting neurosuppressive, if you will, or neuromodulatory agents, where we can start to see, well, hey, right? IL-4, IL-13 is elevated, IL-17, IL-22, IL-31, like where can we start to intervene? And that's actually what we'll get to, I believe, in our next podcast, is talking about how are the current agents that are in development, how are they addressing what is now known about the pathophysiology? How do we maybe more specifically interrupt, again, the neural sensitization and processing of itch that is so clearly important to this disease? And I want to highlight one, point, which is, drugs like we've already referred to, like dupilumab, that we so often associate with being purely anti-inflammatory, right? Blocking the inflammation of eczema, right? That underlies eczema is also key and important to a disease like prurigo nodularis, where those cytokines are increased. And it's not just that they're having an or an inflammatory impact, but they are also regulating how easily those nerves get sensitized or modulated. So if you can interrupt that cycle, right, we'll discuss other drugs that are in the pipeline soon, like nalbuphine, that also may, not only directly reduce itch, but also may impact the ability or the susceptibility, I should say, of nerves to be activated, and then what those nerves do to recruit the machinery to become more sensitized, right? And those pathways, how they become more sensitized. So I think it's a pretty exciting time. And it's great that, you and your colleagues are starting to distill out, well, what are the factors that we can really address?
Absolutely. And I think you make a really great point about how we're learning the most about pathophysiology actually through these very well-designed trials and the interventions. And actually, we had a recent failure of a trial, a drug that blocks substance P called serlopitant that did not meet its primary endpoint in phase 3 studies. And what we're finding, at least from data that we'll talk about shortly, is that modulating the immune component of PN seems to be a real driver of disease. And so we'll touch on that in a little bit in terms of new therapies. But thank you so much, Serena, for a nice discussion.
Thanks for having me. It's been great. I really love talking about all of these PN-related topics.
I know, it just makes me itchy, though. I'm starting to scratch. I'm sure any listeners are starting to get itchy and scratched, too. Mirror neurons, right?
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/P Nodularis 4. Look for all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.